Diagnosis of gastric cancer from whole slide images using state-of-the-art deep learning techniques. Here is the table of contents. First I will go for the introduction, then whole slide techniques, problem statement, literature view, methodology, results and conclusion. Before going to the actual topic and methodology, first I will give little brief introduction about the gastric cancer. Gastric cancer is the fifth most common cancer worldwide and the third leading cancer related to the death. And it is malignant tumor that occurs in the cell of the stomach. There is actually two type of tumors. One is benign and the other one is malignant. So benign do not spread like fastly, but the malignant tumor spread very fastly, like all over the body, specifically to the cancerous part. So the diseases mainly affects men and is typically diagnosed in people over the age of 50. The highest incidence rate in East Asian population. Common symptoms include persistence, indigestion, stomach pain, loss of appetite, and the weight loss. So, what is actually the whole slide image, or what is actually the whole slide image technique? Histopathological medical image analysis essentially in modern healthcare. Before the whole slide image, we was working on the CT scan images and the different other type of images, but those images do not cover the big amount of detail. So it also play a pivotal role in the diagnosis and the treatment of various diseases. Early detection and accurate histopathological diagnosis of gastric cancer increase the chance of successful treatment. Whole slide scanning is powerful and widely used tool to visualize tissue section in diseases, diagnosis, medical education, and pathological research. Whole slide have extremely high resolution. A typical pathology image has a size of 40,000 cross 40,000 pixels. It also have different level of magnification, like 5x, 10x, 20x, 40x. So like as we go for the high magnification level, so we can go more in depth about the tumor area, or we can see the more in detail of those specific cancerous area, or we can say the detail of picture. Here is just sample of whole slide image. So what is actually the problem statement? What is idea behind working this whole work? So manual annotation of cancer tissue is conventional system, can be time consuming and labor intensive. Pathologist shortage also main cause. Efficient, clear and accurate techniques are required to automate this procedure. In the previous traditional system, when any pathologist need to diagnose any cancerous patient, so they need to spend a lot of time to actually cover to check whether this person cancer, this person image, whatever they get the data, they need to go in depth detail whether it's cancerous or not cancerous. So it's also so much time consuming process, and pathologist shortage is also the main reason of this deep learning method. Objective: advanced machine learning and deep learning methods assist to diagnose the gastric cancer. State-of-the-art multi-instance learning showing the promising result for the cancer classification. These methods help to reduce diagnostic variability and human error. These methods can reduce the need for extensive manual labor and expensive sources. foster continuous improvement in healthcare, and enables easy intervention. Here is the literature review. Here is different studies related to like gastric cancer. Some are supervised, self-supervised, and weekly supervised studies. You can see. Here is just the basic overview of whole supervised learning method. Like we just take the label data set, convert into patches, go through the like CNN, and then we like go for the like diagnosis or prognosis, like what are the output, like whether it's malignant tumor or the benign tumor, what are the outcomes on the base of prognosis, like how long this patient can go for the treatment process, or what are the outcomes after this like treatment procedure. Here is the self-supervised learning method. A machine learning approach in which model learn directly from the data without relying the explicit labels. This method designed to generate labels or representation from data itself. It leverages the inherent structure or information within the data. SimCLR involved training a model to differentiate between positive pairs and negative pairs. Model learns the robust features by maximizing the similarity of positive pair and minimizing the similarity of negative pairs. Here is actually the one diagram. I will explain a little bit, then you will get more idea. You can see the original image, then we go for the augmented image, like we apply the different augmentation techniques, like color blurring, like horizontal flip, and the different other techniques to extract the more relevant features, to learn them, to give the more relevant features to the model, so model can learn more better way. Then we go for the CNNs for extracting features. Then those extracting features go into the pre-activation output. Then those activation, like those pre-activation output, go for the multi-layer perceptron, where these whole features combine, and on the base of those combined feature, model like go for the push or like pull representation. Like pull mean like model attract those same images which are like similar to each other, and push those like features which are not actually same or similar. Weakly supervised learning method, a machine learning approach in which model learn from the data, where data have partial or indirect labels. It often deal with ambiguity, uncertainty due to the lack of detailed label, eliminates the need for detailed pixel annotation. It's saving time and effort for radiologists and pathologists. It also deal with uncertain and ambiguous label, such as tumor, like having tumor or not. Automatically generate label for unlabeled medical data, combine a small number of labeled medical images with large unlabeled data set to enhance model training, like distinguish between like benign or tumor tissues to learn more robust features, enhance weakly supervised model by applying transformation like rotations, flip, or noise to medical images. Pseudo label is a widely used strategy in weakly supervised learning, where model generates label for unlabeled data set. Whole slide weakly supervised learning show the promising result in like disease diagnosis, prognosis, prediction, and tumor localization. This also like apply for multi-model data sets, such as combining the medical images with their like clinical data set or their clinical details. This weakly supervised framework also adaptable for various image modalities, include histopathological slides, CT scans, MRI, X-rays, like this, making them versatile in clinical application. Here is a little bit detail about the multi-instance learning. Multi-instance learning is actually the variation of supervised learning, where the task is to learn the concept between the positive and the negative bag. Each bag may contain many instances, but bag is labeled positive if only one bag of the instance in the falls within this concept, and a bag is labeled negative if all the instances in it are negative. Here you can see the like example, red one or the like negative label or negative instance, and the green one or the positive instance. So if in the whole bag, you can see if one bag is positive, a whole bag is considered as a positive. If all the instances in the bag are negative, then we will consider those bag as a negative instance. Oh, sorry, negative bag. Here is the two further types of MIL, bag-based MIL and the instance-based MIL. In bag-based MIL, label are assigned to entire bags rather than individual instances. A bag contains multi-instances, and its label is determined based on the presence or absence of certain characteristics. In the instance-based MIL, labels assigned directly to the individual instance, regardless of their membership within the bag. Each instance is labeled as positive or negative based on its own characteristics. Here is our methodology part. First of all, we go for the data preparation. We use whole slide images data from 4 different Korean hospitals for our study. We use 350 whole slide images from Sinchen, Kyoming, and Bodongcha, which consisting the PD and WMD class. We use 200 PD images and 150 WMD images for this study, and we use 80 images for the training purpose. In the pre-processing, we use the different size and the magnification level. We also convert the all the whole slide images into the same page size 224 cross 224. We also applied the different data augmentation techniques like random horizontal flip, color jitter, random grayscale, and Gaussian blur. Then the augmentation patches are processed to enhance the model robustness and generalization. Here you can see these are the features which we extract by using the SimCLR. We use the 512 features. Here is just 28 features and the details of the whole slide images. Model training. The objective of our method is to classify the PD, PCC, and WMD for weakly annotated whole slide images. For this study, we just consider the PD and PCC as a one class and WMD as a one class. So to perform this experiment, we use the these images. We use the 256 batch size and 50 epochs for training the SimCLR. For computing the features during the training, we use the backbone model ResNet 18. We use the number of features as I showed in the previous slide. We use the 512 features. We use the single level of magnification, and here is our proposed architecture. You can see first we go for the first we take the whole slide images from the different hospitals, then we convert all the whole slide images into the patches. Then we use those patches for the further process. We use the SimCLR. Before processing the SimCLR, we applying the different data augmentation techniques, as I mentioned before, like color jitter, horizontal flip, Gaussian blur, and a few others for the SimCLR process. Then we compute those. We extract features. As I mentioned, we use the 512 features. We extract those features and then compute by using the backbone model ResNet 18. After computing the features, we applied the MIL, and then we train our model data set. Then we use the same our test data set for getting the different other features. And after testing and training, then we go for the attention map. Our main aim was generating the attention map which predict our outcome, whether whether what are the like different areas in the whole slide image are present. We generate this attention map based on the different like attention scores. Here, here is the result. We use the 350 whole slide images, 256 patch size, ResNet 18 as a backbone model. We use the 50 epochs for SimCLR training and 100 epochs for the model training. Then patch size 224 cross 224. We got the accuracy like as a whole accuracy 74.27. And for the individual class, we got the like 73.5 for AUC for the PT class, and for the WMD class we got the 78.5 accuracy AUC. Here is the attention map. This is the simple our whole slide image, and the other one is the attention map. This is the here you can see the like most of the red part. So on the very corner side you can see the like color detail. So as we like go like for the highs in the color details, we can see like when we go for the high attention score, any image or any data get become more red. So this predict like for the very high attention scores, we will get the like PD class prediction. And as we go for the lower side, we will get the very like least attention score. This belong to the normal class, and this also predict the like WMD, like little brown color. Conclusion. The primary objective of this study is to propose MIL architecture that diagnose the PD and WMD class. This model assists the medical stakeholder for the gastric cancer detection. We propose self-supervised architecture for cancer diagnosis and classification. Manual annotation is quite challenging task. Our studies assist to pathologists in working data without annotation. The result demonstrated that the proposed model could be implemented in real-time use. Here is few references. Thank you. Any question, please? Yes, please.
I wanted to see the architecture.
Yeah, sure.
Because I couldn't understand that part. Multi-instance.
Yeah, actually, I explain here the concept of multi-instance learning. Like when we take the patches, like when we took like whole slide image, because this whole slide image is not like for somehow it's labeled. So when we extract the features, then on the base of those features, like we have like say positive and the different negative features. So on the behalf of those features, our model will learn so which are belong to the positive feature, which positive class or positive bag, which are belong to the negative class or negative features. So on the base of those, a model will like furtherly classify and predict. Yeah.
What's the difference from the reinforcement learning and
Actually, reinforcement is the different thing. Like when we talk about the reinforcement learning, in reinforcement, like model force the like those action to learn those specific thing. So, but this MIL, this is the totally different thing. Like MIL learn actually from the these extracted features. Like what inside those image or those like any data set which we use for the extracting features.
In every box,
Yeah.
they will be calculating the positive and negative parts.
Yeah, in every bag they like actually check which are the positive instance, which are the negative instance, based on their like extra their like their scores. So like we can you can say like on if there is one bag, one whole slide image, there are the many like whole patches. So we cannot like elaborate or we cannot label all the patches like this patch is positive bag belong to the positive instance, or belong to the negative instance. So then this model will like learn actually from the relevant part, and on those relevant part it decide whether this part is belong to, or like this part values is belong closely belong to this part or this label or this instance. On this way, like they will classify.
So it's not like the whole image is labeled positive or negative.
No,
the
no.
image is like divided into patches. And
Yeah,
from
then
that
those
patches
patches,
it will,
yeah. Okay.
And
Yes, please.
when we like, I haven't done anything on histopathology images.
Yeah.
You mentioned that they have different sizes.
Yeah,
And
they have different magnification level. Like they're like 5x, 10x, 20x. This is actually their size. When we go for the higher size, we will like see the more detail about those image or the tumor part or inside what actually inside those image.
and all of these sizes will be given to the training.
No. Yeah, no. We actually training sizes are the different thing. Like if it's not actually related to the model training. First, we will take the like different magnification image. We will see like which magnification level we are using for training this part. Okay. Like if we are like for this our model, we use the 5S magnification. So magnification is just the level, just the size. So it's not like specifically related. Like if you are taking the 5x or 10x or 20x or 40x, it's just size. You will get the more detail, in-depth detail about the tumor and tumor relevant part in the image.
I got the part. The main
Yeah.
point is like when you are training that like different sizes.
Yeah.
Do you need to get the exact one size, or you should give all of the?
When actually you will get the one size, it's more better. But if you get the different magnification level, so it's not like any problematic. Yeah.
But in practice,
Yeah.
you can.
Yeah, we can use any magnification level. Also.
Thank you.
Yeah, it's anyone, please. Thank you.